Hi, I'm Dr. Hill with the University of Utah Urogynecology Division.
And I'm Sarah Lenher. I'm one of the urologists at the University of Utah Urology Division.
We're here to talk to you today about urinary leakage, which is a very common complaint for many women.
The first thing that we like to start off with when we're talking about urinary leakage is that there are two main types of urinary leakage. First, there's the leakage that you can get when you cough, sneeze, have to jump up and down, and you get that little squirt of urine. The second type of leakage that we get is when all of a sudden you've got to go. You're trying to find your keys in the bottom of your purse at the back door, and you all of a sudden have that urgency that you need to go and you can't get there in time.
Unfortunately, some women have both types of incontinence. And so today we really want to cover these types of incontinence, some typical risk factors or associations, treatment options, and just give you an improved baseline knowledge of urinary leakage so that we can help women live a better quality of life. So in order to talk about urinary leakage, a lot of women say, well, I have this problem, but how do I get in to see one of these physicians that take care of it?
So we're at the University of Utah, and we definitely can guide you on the best assessment, but a lot of the initial evaluation can be done by your primary care doctor. If you talk to your doctor and you try to explain to them the types of leakage that you're having, sometimes they can start you on some treatments before you even make it to see one of the specialists like ourselves.
So when women come to see us, as Dr. Lenher mentioned, there's two types of incontinence. And I'm going to start with speaking about stress urinary incontinence, that physical activity-related leakage. Primarily, this has to do when the body has an increased pressure in the lower abdomen, and then the urethra doesn't have the strength or coordination to adapt to that pressure. So a lot of it is that the urethra is having a weakness or hypermobile state. So our initial treatment options is really kind of taking a baseline of what you drink, how much you drink, when you drink, and how often you actually empty the bladder. And sometimes even just some simple identification of the pelvic floor muscles, doing the Kegel exercises to help kind of coordinate that can be really effective. After that, sometimes women may even choose to use a pessary, which is a small ring that's inserted into the vagina to support that urethra. These are fit in our office, they're low risk, and many people have been very happy with them for many years if we get that right fit. And lastly, if all these other options don't seem optimal or successful, sometimes you can consider a sling to help kind of permanently support that urethra. And that's where a lot of times patients will come see a urologist or a urogynecologist to talk about those details and more specifics.
Do you want to mention some of the risk factors for the stress incontinence?
Absolutely. So risk factors for stress incontinence are age, so as we get older, pregnancy and childbirth, so not necessarily just a vaginal birth, obesity, heavy lifting or chronic cough, anything that increases that pelvic floor pressure, and then even our genetics and how our bodies have been adapted over time to deal with stress are some of the risk factors that can lead to that. Smoking, it's a cough, but also irritates the bladder, is also one of the known risk factors.
So you can see that there's lots of different approaches that we take to treating the stress incontinence. First, we go from least invasive to more invasive and then most invasive according to your quality of life and what your goals are. And that's where we are here to help you through that process of decision making and find what is best for you. I'll talk a little bit about the overactive bladder.
Yeah.
So the overactive bladder is where all of a sudden you've got to go. You have this sensation, you're in the middle of the store, you see the bathroom on the other side of the store, and you're not going to get there in time, and you have this strong urgency that you need to go. And this overactive bladder is pretty complicated, but it can be related a lot to what we drink and how much we drink. So if you drink things that are sometimes bladder irritants like coffee, artificial sweeteners, alcohol, all these things can kind of irritate the bladder a little bit. And some people, it doesn't bother them at all. But some people you might notice, hey, I have that cup of coffee and boy, I've got to go real quick. So that's one of those bladder irritants. The other thing that I always assess is how much volume you're drinking. If you're drinking 32 ounces, boom, 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 all in a row again and again, your bladder's going to have to go pretty quickly, and you can't necessarily take a medication to make your bladder store more. It just doesn't want to do that. So we look at what you're drinking, we look at the volumes that you're drinking, and we try to come up with a balance for helping you figure out, you really want to have your cup of coffee, well, you might have to go to the bathroom a little bit more often, and that's your trade-off. The other types of risk factors are things like diabetes, poorly controlled diabetes. Some medications can make you have to go more often. And the other big one that a lot of people don't recognize is constipation. So if you have a big stool ball, you haven't had a bowel movement in a couple of days, that stool ball actually sits up next to the bladder but in the rectum, and it pushes up against it. It's kind of like you're towards the end of a pregnancy. There's not much room down there. And so working on your bowels and addressing any constipation you might have is really helpful to help give you a little bit more room for that bladder and less irritation for that bladder. And then finally, like Joe mentioned, for the stress incontinence, genetics sometimes plays a role. Some people just have a overactive bladder and their mom did or something like that. And oftentimes we don't identify what those other causes are. But we do have a lot of treatment options. So similar to the stress incontinence, there's also a tiered approach where we go stepwise through and we work with you on least invasive to most invasive treatments for overactive bladder. And by the way, for the overactive bladder, sometimes you might just have to go urgently, but you don't necessarily leak. That's called OAB dry. And then sometimes you might know you're definitely going to leak, and so that's called OAB wet. Both of them, though, are treated the same, and both of them can be very distressing, especially if your bladder is running your life, as we say. And our job is to help your bladder not run your life. So for the least invasive treatments for overactive bladder is identifying those behavioral things that might be causing you to have that urgency. Do you drink a lot of fluid? Is your volumes pretty high and your bladder just can't handle it? And the third thing is actually delayed urination. It's pretty common that I'll have nurses, school teachers, truck drivers, and they say, God, I have this urgency, all of a sudden I have to go, but they've waited several hours longer than their bladder really wanted to hold it. And so just setting a timer and recognizing that sometimes as you get a little bit older, you can't necessarily hold it as long anymore. And so we say, put a timer on your cell phone and see if you can just go before you have that urgency to go. And that can treat a lot of the overactive bladder type symptoms. And then in addition to those types of evaluations, addressing any constipation and doing pelvic floor physical therapy can also help overactive bladder, just because you learn how to get a little bit more control over your bladder and calm your mind, let that urgency spasm pass, and then gently go to the bathroom. And pelvic floor physical therapy will also help with stress incontinence. For next line treatments for overactive bladder, it's mostly medication based. So there's some medications that help the bladder store. And we have several different types of these medications. The problem with a lot of the medications is they have side effects, namely dry mouth, constipation, and sometimes can cause some brain fog. And so those medications are like Detrol, Ditropan, Oxybutynin, Tolterodine, Sanctura, Fesoterodine. There's a whole bunch of them that you maybe have been tried on by your primary care doc, and you might have noticed dry mouth or other side effects that were bothersome. There's another class of medication that doesn't have those side effects. However, right now it's kind of expensive, and so it's hard to get a lot of patients on it. But more of those medications are being developed and are going to be released soon, and so we'll have more options for medications. The other thing that we always recommend in women that have overactive bladder is that we offer the option of placing vaginal estrogen in the vagina to help with relaxing the bladder and helping reduce the lack of estrogens that are in the vaginal area that can be associated with aging. And a lot of women get more overactive bladder as they get older. And if these types of treatments are not satisfying and get you to the best quality of life that you're okay with, then we can talk about third-line treatments for overactive bladder, and those include two different classes of treatments. One is a neuromodulation type system where we change the way the bladder works by affecting the nerves, and the other way is by chemically blocking the bladder spasms with Botox. And this is similar to what is done for cosmetic Botox, but it's FDA approved to inject into the bladder and make the bladder relax a little bit more. And similarly, the nerve treatments with neuromodulation can also help stop the bladder from spasming.
Great. So you can see there's lots of options, and you have to think about the level of bother should directly correlate with the level of severity of that intervention. And everybody is very individualized along where they've been, what they've tried or haven't tried. And so our job is to help you tease that out, but also to make sure we keep you safe and keep improving your quality of life. And if you are one of those lucky women who have both types of incontinence, it's really important to understand how the treatment mechanisms differ for both. So the stress incontinence is really an anatomical issue. So you're focusing on the anatomy of the urethra, whereas overactive bladder has a lot to do with the sensitivity and how that brain and bladder are communicating together. So fixing one may not necessarily change or fix the other, and that's why you have to be really clear that if you get a sling, which a lot of women have had, oh, I had that sling, but I'm still leaking urine. Well, it might be more of an overactive issue bladder that we've just uncovered. And so that's why just having a good detailed discussion and history and an examination of what type of leakage occurs is really key so that you get maximum benefit, but also educating you on how your body and why it's leaking.
The other thing that we importantly want to make sure is that you're safe and we're not missing something like a cancer that might be causing your bladder to be overactive and things like that. So if you have any concerning other symptoms, you definitely need to see one of us for further evaluation, such as blood in your urine that you can see in the toilet bowl, a strong history of smoking, which increases your risk of bladder cancer, and recurrent urinary tract infections can all be markers of something else is not necessarily happy in the bladder, and that we need to evaluate you to make sure that things are safe and we're not just dismissing it as you're getting older and you're going to just have that leaky bladder.
And so in order to come see us, at least to get into our system, is we don't really require a referral for urinary incontinence. We do ask you some questions in regards to try to help best facilitate which provider you get to see. So we might ask some of those questions. A lot of times patients start with their primary care physician as an initial kind of step, and then they can refer into us. In regards to get into a pelvic floor physical therapist, they typically do require a referral, but that can come from our office, your primary care, your OBGYN's office, as they're kind of our partners in crime to kind of help you understand the pelvic floor a little bit better.
I'll actually mention a couple more lines about the pelvic floor physical therapist. Like she says, they're our partners in crime. We love the pelvic floor physical therapists. These are special physical therapists that have gone through all the training to help you rehab from your knee replacement or something like that. But they have dedicated their practice to working with you on your pelvic floor and how your pelvis and your bladder and your urethra are all working together. So how your bladder fills and then how you empty. And they are really great at teasing out some additional details. Maybe you kind of sit funny. Maybe you need to go back and pee twice or something like that because of the way you're sitting on the toilet. And so they really are helpful in teasing out those details and can give so many people insights into how things work down there, more than we have the time or expertise to explain. And so it's really exciting when patients come back and they're like, I learned so much on that visit. And they'll work with you, they'll get a history, and then they'll generally do a physical exam both internally and externally to see if there's any nerve issues or other types of things that we didn't pick up on.
Yeah. So again, urinary leakage, very common. You're not alone, but it's one of the things that sometimes it bothers some women more than others, and that's okay. And that's where you, as the patient, gets to desire and the drive of how much intervention do we do, where do we go, and just know that you're not alone and there's people that are here to help and that can make your quality of life better.